Thank you, Nirmal sir, for this wonderful opportunity. My talk will actually be a continuation of what Nirmal sir had spoken, how to assess a patient planned for OP or daycare surgery. Well, the goals for a good pre-surgery evaluation starts with having a rapport with the patient. Most of the medico-legal issues or the problems that we face are not actually because of the complications that we've had. It's mainly because of the language or the patient not getting a rapport with either us or our counselor. That is where problem happens, verbal exchanges happens, and we get into trouble. So once a rapport is created with the patient as well as with the family or the attender, the game is half won. So allaying anxiety is very important. This helps them to reduce the morbidity of surgery. It helps to reduce surgical delays and case cancellation. This is one of the most important factors for successful daycare surgery. And of course, in today's world, safeguarding us is very, very important. So who is fit for daycare surgery? By the ASA classification, any patient who comes under grade 1 or 2. Grade 1 includes a normal healthy patient, and grade 2 is a patient with mild systemic disease. They can be comfortably taken up for daycare surgery. Age, however, is not a defining factor, but in general, a patient more than 80 years of age has a slightly more risk of developing complications. But in today's world, we cannot ignore even a 50-year patient who looks fit to us. Certain basic evaluation is always a must. Next, coming to body mass index, BMI of less than 40 can be considered safe as long as comorbids are controlled. A patient with approximately 50 BMI is a relatively risky area, and certain consents has to be taken, and we need to have good surgical backup in case we face any terminal events. BMI between 40 to 50, they include patients in a relatively gray zone, and they should be considered on a case-to-case basis. A good preoperative evaluation involves a proper history taking from the patient, general and systemic evaluation, lab evaluation, expert opinion, and most importantly, consent has to be taken. So this is something which most of us were interested in. However, now again we are going back to pre-COVID time. If in case we have another wave, we should look at it. For a patient, I think most of us or all of us would have had one shot of COVID at least. So a patient who's had a mild COVID and recovered without much non-respiratory complications or symptoms, we can take up that patient 4 weeks in case they are asymptomatic, 6 weeks for a patient who's become symptomatic but did not require hospitalization, recovered at home. 8 to 10 weeks for a patient who's been symptomatic, diabetic, immunocompromised, or has undergone hospitalization. 12 weeks for a patient who's been sick, admitted in ICU, and had intensive care treatment. With regards to history explaining the current symptoms has to be taken. Most of our patients, if you notice, will be having some comorbid conditions, diabetes, hypertension, COPD, seizure disorder, or CVA, thyroid disorders. These things has to be taken. Well, I came up with this fancy term with one of my anesthetist friends. She said that you need to ask for effort tolerance. I asked, what is effort tolerance? She said, very simple. Doing your routine work without much difficulty. Or you can make the patient climb a fleet of stairs and see if they are comfortable. So that is what they mean by effort tolerance. If that is done, it gives a rough idea that the patient is reasonably fit. Medication history again is very important. Most of our patients again will be on either one of these drugs. Blood thinners is something most patients above 60-65 take, inhalers, steroid usage, and anxiolytic. When to start or stop a blood thinner? I feel this decision has to be left to the physician or the cardiologist who started the drug to decide. But in general, if a patient is on warfarin or on clopidogrel, it's advisable to stop for minimum 5 days. It doesn't make sense stopping it 1 or 2 days prior, because the drug works for 5 days. So if it is not stopped for 5 days, stop the day before, it's as good as not stopping at all. If a patient is on aspirin and the patient is having some high risk CVA incidents, it's better not to stop. when to restart or resume the drugs. If we are expecting low risk of bleeding, it can be resumed even the next day. When we are anticipating high risk of bleeding, wait for 2 to 3 days. Maybe an orbital surgery or a DCR is done, it's ideal to wait for 2 to 3 days time. General examination, we should assess the general condition of the patient, look for hydration status, orientation, pallor, cyanosis, clubbing and pedal edema. Systemic evaluation, a thorough evaluation has to be done. CVS, RS, abdomen and CNS evaluation has to be done. Lab investigations, I feel in today's world it is mandate to do certain basic tests before we take up a patient for surgery. Hemoglobin is mandate. Why is it mandate? In case a patient develops some complication, that time our anesthetists or the hospital where we shift the patient asks, first thing they will ask is, what was the hemoglobin of the patient? If we are clueless, then treating the patient becomes very difficult. A total and differential count helps us to come to a conclusion whether the patient has any active infection at present. Blood sugar level again is very important. High blood sugar levels should be controlled and then the patient should be taken up. Why urea and creatinine? Most of us do give NSAIDs post surgery. In case it is other than cataract, maybe again orbital or any other surgery, a lot of NSAIDs are used. In fact, steroids also are used. So we need to know the urea and creatinine level before taking up the patient. ECG, it gives a rough idea about the heart's working condition. Chest X-ray, we've been doing, at least I was doing during the first and second wave, a digital X-ray because some patients were not willing for a CT scan. If patients were willing, we were doing, but at least a chest X-ray has to be done. Now again we are going back to pre-COVID time. Echo, of course, for patients who are at risk. Coagulation profile is a must in case we are anticipating high blood loss. Serology again for our safety. Well, how expensive are these tests? This is much cheaper than the biometry for most patients. If you see, the total cost of these basic tests will hardly come to around 1,500 to 2,000 rupees. If we exclude the profit margin and tell a lab guy to come and take, he may charge us maximum 1,000 to 1,200. I feel this is honestly worth it for our peace of mind. Expert opinion, if needed, should be taken from specialists. A cardiac opinion if the patient is having any effort tolerance issues, or a pulmonologist opinion. Endocrine opinion for patients with high thyroid. I had an incident very recently, had a special child was around, the mental age was around 15, the child was around 25 to 30 years of age, posted for cataract surgery. Physician saw the child, did echo, all investigations. Then I told her she was a post-uveitic cataract, so we wanted to give steroids. Then the physician said, sir, we have to do a thyroid profile. I had no idea why she's asking me to do thyroid for a patient. I want to give steroids. And luckily the patient was having hypothyroidism. So that was brought under control. We postponed the case for about 2 weeks. Steroids were started and then treated because they said, in fact, it was news to me. The anesthetist said that they may be having a steroid storm. If you give more steroids on table, we give a GA, they can go in for shock. So that was a learning curve for me. This happened hardly, we operated hardly 1 week or 10 days back. It was an incident which happened last time. This was a learning which happened very recently. Consent is something very, very important. Gagan sir and Nirmal sir were consistently saying consent is very important, how consent has to be taken. One consent paper for the surgery and anesthesia is no longer valid. It's absolutely void and it's history. Separate consent form has to be there, one from the one anesthetic consent and one surgical consent in the regional language. This is something that we do in our center. We make the physician see the patient and there is a easy tick for them to check what is needed, what to be done, and a signature is put. This helps us to have a documentation. This is something that we do for all of our patients. Getting a patient to assess our patient and to getting a clearance for surgery is very vital. It is a myth that the patient will run away if we make this patient spend another 300 or 500 or 1,000 rupees more to see a physician. If we make the patient understand that it is for their benefit and we don't get anything out of it, most patients in today's world will be willing to meet a physician and get it done. Maybe if we don't have a high volume practice, maybe 1 or twice a week, cataract patients or the patients can be pulled up, physician can be told to come, they can assess the patient and give a clearance. counseling plays a big role in patient satisfaction. As I said earlier, the first point was creating a rapport. That is something that is very, very important. Once patient feels comfortable, they will be willing for most ethical tests that we do. It is always safer to be a king in ophthalmology and live life king size rather than to be a jack in anesthesiology or in cardiology, mess up our patient and then get into trouble. So let's stick to what we know best. The common myth, or at least even I was under that feeling, if we send a patient to anesthetist or to cardiologist, they either postpone or they cancel the case. Well, of course, that is happening, that is for our benefit. And one more thing that we found was sometimes the physician has to be clear what surgery or what we are planning to do. This is what we want, this is what is the surgical time, this is what is needed. Once that clarity is given, it makes things easier for them also to give. Just like that patient going and saying, I want a fitness for surgery, then a lot of other investigations are done and the patient also goes through quite a lot of trouble. So let's stick to what we know best. Anesthetists and physicians are our saviors, not only for us, they are saviors for our patients also. Thank you. I'd like to thank AOS, Partha sir and Nirmal sir for this wonderful opportunity.
Thank you, Atik. That was a wonderful presentation, and thanks for that clue to become a king in ophthalmic practice. It is indeed important that we have the team, and our team includes anesthetists. So most of us are hesitant to call anesthetists for a local anesthesia case, and it is our work. But in such emergencies conditions and in the stressful theatre days, having an anesthetist really relieves takes care of your blood pressure during the crisis situation. That is more important. So living king size, that is different. But definitely the anesthetist in the room gives a lot of confidence to us, as well as for elderly surgeons like me. It gives a lot of confidence that they can tackle and control my blood pressure also. And second thing, they are very, very good companions. Even before the patient can start giving trouble, they can identify and help us. So just one dose of midazolam really helps these patients, and now I become very fond of this monitored anesthesia care. The patients are really happy. At the end of the day, end of the surgery, after even 5 to 10 minutes, they walk back and they are very happy that their anxiety and pain has been taken care of. As physicians, very, very important that we take care of the pain aspect. We have a pain scoring done in our center. Jayantan, ready? Let me know when you're ready. So we are doing a pain scoring in our center, as well as another thing called patient reported outcome measures. How comfortable the patient was during our topical anesthesia or peribulbar anesthesia. Even though we are very, very confident about our surgery under topical, patient, because of their anxiety, they do experience pain. So we also did a matching study between one eye where topical was given and one eye where topical with midazolam or short anesthesia was given. Patients are really happy with short anesthesia. So if you have VIP patients where you are also anxious, it's always better to have an anesthetist and also ask them to give a monitored anesthesia care. The surgery goes on smoothly, and the patients and the surgeons